Discussing healthcare facilities. One thing I do want to say is we'd like to ask folks to keep their testimony to 3 minutes. We have many bills in this committee that have heard, and we find it to be important that the first folks we hear from, there are also people here to listen to the last set of folks that are in here, all that being based on the number of your bills. So people who keep their testimony to 3 minutes, I would be very grateful. And I would like to start with Rep. Atkins and House Bill 3514.
Thank you, Madam Chair, Mr. Chairman, and through you to the members. I'm State Representative Corey Atkins. I represent the 14th Middlesex District. I am here today to testify on 2 very critical public safety issues. One is the use of concurrent surgery, and that is the practice of a surgeon performing 2 surgeries at the same time. And the other is, while doing so, they do not disclose the practice or that the surgeon plans to do this type of surgery to the patient who's being operated on. And why I think this is so critical is because if you're in an operating room, I don't know how many of you have had the glorious experience, but you're naked, you're knocked out, and you have no advocate in that room except your surgeon. That's the person you've been conversing with. So you don't know who's in that room or who isn't that room. This bill was prompted by a Globe Spotlight team that illuminated this practice that goes on quite frequently at the Mass General and at other major teaching hospitals. And what happens is that many of these hospitals did studies after this practice was exposed and to highlight that no, this really wasn't causing any difference in the outcome for a surgeon to go from one surgery room, operating room, to another. Canada wasn't satisfied with that because its samples were very small. The length of time that the sample looked at, the patient's any complications, was also small. And how would they know if the doctor had been in or out of the operating room? Because presently, under the law, the doctor, the surgeon, the one who's supposed to be in charge, is the only person in that operating room that is not required to sign in or sign out. So nobody knows. They all have to be in a range of a quarter a mile away. So some surgeons, while the surgery that they're in charge of, have been at their office at the child's office park while their patient is in surgery. Canada did a study of 90,000 patients to see what the actual effect this had on surgeries. And when they did 90,000 patients, they also followed their outcome and the follow-up for an entire year to see which patients and had serious complications or required further surgery because of things that did or did not happen during that surgery. So I am humbly requesting that you protect the citizens and residents of the Commonwealth when they're in their most vulnerable state, when they have no one else that can advocate for them except us by providing the law that their surgeon with whom they contracted be there. And I hope that you support House Bill number 3514
Thank you, Rebecca.
out of the
Thank you
committee.
very much. Does anyone on the committee have any questions? And let me introduce to the committee while I'm here, Jonathan Eck from Watertown, Paul Schmidt from Westport, Jack Lewis from Framingham, Rep. China Tyler from Boston, and Hank from Shrewsbury. Welcome, everyone.
Thank you.
I would now like to bring up the Massachusetts Pain Initiative, Cindy Steinberg, Ethel West, Lauren Luna, please.
Good afternoon, Chairwoman Hogan and other honorable members of the committee. Sure. Good afternoon, Chairwoman Hogan and honorable members of the committee. My name is Cindy Steinberg and I live in Lexington. I am here representing the Massachusetts Pain Initiative, or MSPI as we call it, and the USA Pain Foundation, both of which are nonprofit organizations that are dedicated to improving pain care in the Commonwealth and the nation. Policy chair for MSPI and National Director of Policy and Advocacy for the U.S. Pain Foundation. We are all here in support of House Bill 1181 and Senate Bill 1183, an act requiring pain assessment and management in healthcare facilities. We have two panels, so myself and two people with me are people living with pain, and then we have two healthcare providers, two people living with pain, and members of MSPI. Everyone in this room, committee chair included, committee members included, will at some point in their lives have pain that sends them to the hospital, whether it's because you broke bones or whether you cut your hand, you're cutting the bushes or something, or whether you have severe migraine or whether you live with painful conditions like endometriosis and pancreatitis, like my colleagues here. Or you could be in the hospital with severe pain as a result of major orthopedic surgery, perhaps joint replacements or severe and major back surgery. Or perhaps you've been in the hospital with a loved one, a child who's had an accident, or a parent, usually like my mother, who lost her leg or painfully diabetes. The point is that all of us will experience pain in a healthcare facility in Massachusetts at some point in our lives. Don't we all deserve to have our pain assessed and managed when we enter a healthcare facility? Should we all have that expectation that our pain will not be ignored, that pain assessment and management is a basic human right? We know that untreated or undertreated pain can lead to much worse pain and great physical harm and mental harm. Most pain, whether it's acute or chronic, can be managed to tolerable levels with proper pain assessment and management. There's no reason why anyone should have to suffer. Right now, the patient rights legislation in Massachusetts, or the statute, doesn't include the right to have pain assessment and management. House Bill 1181 and 1183, it basically adds to the patient's rights law the right to have your pain assessed and managed when you enter a healthcare facility in Massachusetts. Right now, 19 states have this in law, including Vermont and Rhode Island in New England. The Joint Commission does have this standard for pain assessment and management, but not all facilities are accredited by the Joint Commission. So, for example, in Massachusetts, nursing homes, assisted livings, and surgical facilities don't have a requirement for pain assessment and management. There's no cost to the Commonwealth. The passage of this bill, the bill was reported favorably in past sessions out of this committee. We believe strongly that every citizen has the right to have their pain assessed and managed in a healthcare facility. So please report hospital eliminating free or eliminating one favorably out of the field. Thanks for listening.
If you could just talk to the songs and the fighting air conditioning you didn't leave in December, heat your room.
No problem.
You can with the mic, but nobody wants to hear you.
Thank you. Thank you so much for having us today. My name is Rebecca West. I live in Quincy, Massachusetts. I've been living with chronic pain for half my life, and I'm 27. This bill is so important to protect every citizen of our Commonwealth from the traumatic experiences that I and many other people I know living with these health problems have had in their lives. Having pain assessed and treated should be a basic human right. Our Constitution entitles us to life, liberty, and the pursuit of happiness. When you are constantly in pain, without your pain being taken seriously, without a diagnosis, and without getting sufficient treatment, you don't have any of these rights. Pain is untreated and undertreated consistently in the medical community. Besides the immense suffering that this causes patients, pain is very often a sign that something seriously medically wrong is happening in your body, which is one of the reasons why it needs to be taken so seriously. I know how important this bill is from my many personal experiences with the medical community. In 2010, I went to the ER with extreme pain due to what I was sure was an ovarian cyst, a condition I've had flare-ups with for over half my life. I explained my symptoms, my history of chronic pelvic pain due to both endometriosis and reoccurring ovarian cysts, a condition which needs to be diagnosed and closely monitored because it can require surgery and can be life-threatening. The ER doctor questioned and interrogated me over and over again, insisting I had nothing wrong, trying to find a hole in my story. He refused to do an ultrasound and told me it was too late at night for him to order one. It was 10:30. I had gotten previously CT scans at the same hospital at 2 in the morning. He told me, "We do not treat pain in the ER." I begged and pleaded with him just to do an ultrasound to give me something for pain. I asked for Toradol, a powerful anti-inflammatory with absolutely no risk of addiction. When my husband expressed to him that I was not receiving sufficient pain treatment, the doctor got 2 inches from his face and yelled over and over again, "Are you a doctor? Are you a doctor? Because I'm a doctor." When you go to the hospital for pain treatment, especially when you are my age, in today's environment, you are immediately assumed to be a drug seeker. The doctor accused me of being a drug addict and trying to abuse and game the system because I had had prescriptions written in the past for pain medication from my one OBGYN and my one PCP, both of whom were aware of the prescriptions. He forced my husband out of the room against both of our wills. He then proceeded to perform the most painful pelvic exam I have ever had in my life. I was screaming and squirming in pain. I begged him to be gentler, telling him over and over again how much he was hurting me, that this was too painful to continue. He said nothing. Neither did the nurse who was standing over my face, watching me contort in pain and watching me scream, begging for the pain to end. Every time I screamed, he pushed his fingers deeper inside me and pushed harder down on my abdomen, becoming more rough with every sound of pain I made. He told me I definitely didn't have an ovarian cyst. This is something that cannot be definitively determined from just a pelvic exam. When it became apparent he wasn't believing me, I stopped asking for my pain to be treated and only asked for an ultrasound so that I could know if I was having a flare-up. 2 days later, I returned to the same ER, still having horrible abdominal pain. Yeah, I have 2 seconds left. 2 tiny things. This doctor too started to write me off as just another chronic pain patient, but did agree to order an ultrasound. After my ultrasound, she came running back into the room. I've never seen a doctor run like that. She told me, "You have a very large hemorrhagic cyst on one ovary and another cyst on your other. You're in a lot of pain." She then ordered the nurse to give me medication to treat my pain. Imagine watching your wife, your daughter, your mother, your loved one laying in a hospital bed, begging just to have someone look into the reason why she is in so much pain. So much pain that she is crying, her face and body contorted, begging for help and receiving none. Please pass this bill to prevent this from happening to yourself or someone you love. And please refer this bill favorably out of your committee. Thank you. Good afternoon. Good afternoon, Chairman Lewis, Chairman Hogan, and the honorable members of the committee. My name is Lauren DeLuca, and I live in Worcester, Massachusetts. I support House Bill 1181 and Senate Bill 1183. I suffer from a disease called chronic pancreatitis. Chronic pancreatitis is when the enzymes that are released to digest your food actually back up into my pancreas, and I start to digest my own organs alive. It is known to be one of the top 5 most painful diseases in the world. Unfortunately, in the current political environment, someone like me who goes with an extremely painful condition and goes to the emergency room is immediately summed up as a pill seeker. And in addition, unfortunately for me, my condition displays very much like a heroin withdrawal, that I will start to sweat and I get cold and hot sweats. I will lose control of my bowels and I will go into cyclical vomiting for days. More than one time this year, I've been denied access to having my pain addressed properly in an emergency room setting. One time I was rolled out into a cold hallway and ignored for 3.5 hours. They wouldn't even give me IV fluid to help hydrate me, even though they were watching me slip with vomit. And they refused to give me Zofran to prevent the cyclical vomiting, and they wouldn't even give me a glass of water. I eventually stood up and wanted to leave because they weren't helping me. And they told me to walk several blocks back to my car without even addressing my condition at all. Well, they snickered at the fact I was in pain because they assumed I was there for the pills. The result of this was between May and September of this year, I lost 11% of my organ function, and that is never coming back. And now I'm an intractable pain patient. Had I been helped in May, I would not be in the health condition I am in right now. I've lost over 20 pounds of my body weight, and I continue to lose weight every day. I recently had to step down from my job as a commercial insurance agent because I had the inability to eat solid food, and I've been reporting this for weeks, and nobody seemed to care or believe that this was happening. And what's happened to me can't be undone, but I'm here today so it doesn't happen to other people. I live in constant fear because these attacks can happen at any time, and I've already lost 11% of my organ.
I may have lost more since September. I don't know if I'm going to get helped the next time I go into an attack. But if I do happen to live through these attacks, every time I have one, I'm sicker than the day before. My example is the illustration as to why pain needs to be treated immediately. Failure to step in causes me organ damage, and my attacks can turn fatal very quickly. Thank you for listening. I appreciate all of your time, and I hope you will refer this bill favorably out of the committee.
Thank you, Lawrence. Are there any questions?
There was one other thing. I wanted to see if I could submit a couple pictures to the committee.
Yes.
These display what's happened to me in 2 months. And these pictures were for 4 weeks ago. My body is worse now. So I'd just like to submit this as evidence for my testimony. Thank you.
Thank you all very much for your testimony.
Thank you so much.
The next set of folks on Mass Pain Initiative is it Paul Arnstein and Lily Bradshaw. Please.
Good afternoon. My name is Paul Arnstein, a PhD prepared nurse living in Charlestown, Mass. I'm testifying on behalf of the Massachusetts Pain Initiative as a member of their policy council. I'm speaking today in support of House Bill 1181 and Senate Bill 1183, an act requiring pain assessment and management in healthcare facilities. Over my 40-plus year career in healthcare, I've worked as a nurse's aide, a registered nurse, nurse practitioner, professor of nursing, and now serve as a Cornell Nursing Research Scholar and a clinical nurse specialist for pain relief at Massachusetts General Hospital. Today's greatest tragedy in healthcare is the way patients with pain are being ignored and mistreated. Patients seeking professional help for pain face stigma, shaming, and shunning that makes it difficult to access care and live a productive life with dignity. The conversation in recent years has been dominated by the current epidemic of opioid abuse. The reality is that both chronic pain and substance use disorders are catastrophic health problems. Mass media increasingly presupposes that all pain is about opioids and all opioids are about substance abuse, but these assumptions couldn't be further from the truth. While opioids, when taken appropriately, do help a subset of patients, there are a plethora of other ways to manage pain. Also, repeated scientific studies have demonstrated that less than 8% of people who are prescribed long-term opioids for pain abuse them. An estimated 50 million Americans experience acute pain from major trauma or surgical procedures annually, and 20 to 50% of them go on to join the ranks of 100 million Americans living with chronic pain, especially when their acute pain is undertreated. Intense ongoing pain creates degenerative changes throughout their nervous system, affecting brain mass, memory, learning abilities, and behavior across the lifespan. From the point of view of pain treatment in healthcare settings, I've witnessed a historic pullback in the enthusiasm and effectiveness in which patients with pain are being assessed and treated. I've held down children while doctors cut and sewed their faces without the benefits of pain relievers. I've witnessed a dying sickle cell anemia patient with painful clots destroying his bones have pain medicines that were helping him get out of bed, enjoy TV shows and conversations, have his medicine stop because he had prior drug use. With no other pain reliever put in place, he was left bedbound and moaning for weeks until he died. I've had a prominent surgeon refuse to prescribe pain medicines 2 days after major chest surgery, telling the patient, "I'm not allowed to prescribe them," after the STEP legislation went into effect. When the truthfulness of that statement was challenged in private, he admitted, "Pain bores me, that's why I became a surgeon." I've seen a nursing home patient with inoperable spine and hip fractures screaming as she struggled to get to the bathroom after being given sugar pills instead of pain medicine. Found out later that was a routine at that nursing home. These and so many other vulnerable patients need protection of legislation that acknowledges the evaluation and treatment of pain as a basic human right afforded to all citizens without discrimination. When the Joint Commission updated their 2018 pain standards, they and all the experts in the room that they convened had agreed that the statement that is on the books, "The hospital respects the patient's right to pain management," needs to remain in place because that right is increasingly violated. Bills 1181 and 1183, if enacted, would extend the rights to non-accredited healthcare settings, nursing homes, clinics, surgical centers across Massachusetts. It would align our state with the World Health Organization, United Nations, National Academy of Sciences, and 64 nations that agree there is a moral imperative to ensure that pain is addressed in all healthcare settings, and it would align Massachusetts with 19 other states that have recognized this right in statute. We do not believe that all patients have the right to access opioids, but do have the right to have their reports of pain taken seriously, their condition be evaluated, treated, or referred in a professional manner without being shamed or shunned. Thank you in advance for recognizing every Massachusetts patient's right to prompt pain assessment and treatment by referring these bills favorably out of committee.
Good afternoon, Chairman Hogan, Chairman Lewis, and honorable members of the committee. My name is Libby Bradshaw, and I'm a physician. I'm the academic director of the Masters of Science program in Pain Research, Education, Policy, and Public Health programs at Tufts University School of Medicine. This is an academic program that focuses on the burden of pain for the U.S. population, individual patients, our healthcare system, and overall society. I would like to express my strong support for these bills. In my clinical life, I was an emergency physician for over 20 years, and I've seen pain from trauma and multiple diseases. Treatment of pain is essential, and over the course of my time in the profession, I've seen many improvements in pain management. In the current era, though, we are really moving backwards in time, and the kinds of stories that Dr. Arnstein has said and the patients from the panel have said are really true, and we see them on an accumulating basis where clinicians are feeling under pressure to do something, and in fact one of the things that they often do now is to ignore or minimize pain. We, however, know from the accumulating research in pain and the neuroscience of pain that attention to acute pain can ameliorate the severity and sometimes prevent entirely the progression of acute to chronic pain. And this is an important dimension of pain care, and it's one of the reasons that this bill is important. This research is being prioritized at the NIH and other international scientific organizations and funders. Typically, we divide pain into three categories: acute, chronic, and cancer pain, but pain can be divided in multiple ways as well. We can divide pain into a normal nervous system type of pain and pain from an injured nervous system. The type of injured nervous system, for instance, is the kind of pain with shingles, where there's actually an injury and then a problem with the nervous system functioning. There is also great biological diversity in how patients individually respond to pain. This is partly based on the mechanism of injury, prior injuries, the painfulness of the disease process, and their pain management experiences. It is partly based on the multitudinous differences we carry in our human genome that determine how pain is signaled in our body. There can be significant differences in functioning from individuals to individual. There are also significant personality differences in how we respond to pain. For some individuals, pain biologically triggers a lot of anxiety and even depression, both of which increase pain signaling, the experience of pain.
other individuals experience pain more stoically. There's been a lot of research in pain, in the pain field, that demonstrates that we as healthcare professionals were unable to predict what a patient's level of pain is without directly assessing that pain. Because pain is subjective and the actual pathological processes that occur in the neurological processing of pain, it is not predictable at the individual level. And management strategies, both drug and non-drug, are improving, but will often require a trial and error approach. We can't predict which individual therapy may be more effective than another drug in that same class. So in closing, pain is a fundamental component of medicine, but it is because of the twin crises of undertreatment of pain and our opioid crisis, it is really, there's been an imbalance now. And we need to address that as a common. I really hope for your support for HB 1181 and SB 1183.
Thank you both. I think we were very interested to see the greater length and of course considering whether for exception
Would be happy.
Is there anyone else who has any questions? Seeing none, thank you very much for your testimony.
Thank you.
I'm now calling on Shauna O'Connell, please. She has a group with her. Marlene, Nancy, Penny, and Leslie. I would also like to welcome Reverend Keith.
While they're getting seated, I'll just really quickly, if that's okay. I just want to, for the record, also state that my favorable testimony and support for H1143, an act relative to closing of hospital essential services, which I'm sure you know provides more oversight, scrutiny, and community involvement when these essential services will be closed, which we see happening all too often. It puts our communities in danger by limiting their access to those services. We're here to testify on H3250, an act relative to informed written consent for the use of psychotropic drugs, which has been described as an epidemic across our country by federal advocates. This bill strengthens our current informed written consent laws and makes them consistent across facilities to include nursing homes, hospitals, and rehabilitation centers, which we don't have that consistency right now. This is a refile, and it has been modified to address concerns that we've heard in previous years from stakeholders. For example, informed written consent would only be twice a year rather than previous every quarter that we had suggested before. So I'm going to submit written testimony. I've already submitted that, and I want to let these ladies testify. First, we're going to hear from Arlene Germain, who is the president of Mass Advocates for Nursing Home Reform, and also representing Greater Boston Legal Services on behalf of their clients. Thank you, Arlene.
Thank you. Good afternoon.
Oh, nice and close, Arlene. No voice.
I do have a second. We are in strong support of H3250, which mandates informed written consent before the administration of psychotropic drugs to patients in hospitals and rehabilitation facilities. And it also expands the rights for nursing arrest home residents under existing consent law. The bill ensures that you are given critical information about the drug, alternative treatments, emergency protocols, your right to refuse or discontinue the medication, and much more. And most importantly, you have the right to say what happens to your mind and body. Psychotropic drugs have positive outcomes when used as intended. However, they can have a devastating effect when misused as a chemical restraint to manage what are labeled as inappropriate behaviors. Behaviors that are really misunderstood communications of medical, emotional, or other problems. Antipsychotics have many serious side effects and an increased risk of death, particularly for the elderly. And there is the danger of substituting other drugs to still create a chemical restraint
that robs people of their identity and dignity and can also lead to physical injury. A dramatic example of the need for further informed consent protections is the misuse of antipsychotic drugs on nursing home residents with dementia. This reached crisis levels across the nation, and sadly, Massachusetts still has one of the highest antipsychotic usage rates in the country. We're ninth from the top. That's how high we are in the country. This crisis extends beyond nursing homes. According to the federal government, the problematic use of drugs such as antipsychotics is part of a larger growing concern that nursing homes, hospitals, and other settings may use medications as a quick fix for behavioral symptoms or as a substitute for a thorough assessment and quality care. A 2016 study of assisted living residents substantiated their concern. 76% of residents have a dementia, and 37% of those residents were given antipsychotic drugs. By 2035, 65 and older adults make up 23% of the Commonwealth's population. And the number of Massachusetts residents with Alzheimer's will also increase by 25%. How to keep our elders, how to keep ourselves safe from the misuse of these dangerous drugs is a growing crisis. But the first step is ensuring that people have a voice in their own care, that they have informed consent before given a mind-altering drug. There is a devastating human cost and a substantial financial cost of providing poor care, and we urge you to support H3250 to ensure that no one is ever subjected to the pain and suffering caused by the misuse of psychotropic drugs. Okay, thank you.
Thank you. Next you'll hear from Nancy Sylvester. I'm sorry. You'll hear from Nancy Sylvester, who is close family friend who was a victim of the overuse and misuse of these psychoactive drugs. Okay. Nancy Sylvester is also a teacher, so I have my boards, but I just want to explain this to you. Bob, which was a friend of my father's, a 35-year veteran on the city, as was my father, came to me for help, and this is what ended up happening. I want to explain it. Advocates described this man before this whole thing started would be outgoing, witty, strong, active, articulate, well-read, musical, talkative, and intelligent. Advocates, which I found on his medical records 2 weeks after this whole thing began, unwilling, disinterested, reluctant, nonverbal, confused, lethargic, and unable to participate. 2 weeks, this whole change. This is Bob 2 weeks before the incident. He was at a health meeting. This is Bob 2 weeks later. I use pictures to show you how drastic the change was in him. All right, and why was it changed? Well, because there was a cocktail of different drugs being given to him without family's knowledge. They were Ambien, Trazodone, Memantine, Seroquel. All of these had these side effects such as memory changes, agitation, anxiety, irritability, swallowing, which we did not know were being caused by this. But they just treated these side effects. So he ended up with a feeding tube in 2 weeks. He ended up with a feeding tube. He ended up with unable to speak, unable to exercise. At some certain point, he'd catch on and he'd say to me when doing exercise, this is what I want, just tell me what to do and I'll do it. But again, he couldn't because he was so drunk. My throat hurts, my head hurts, and my heart is broken. This is a man who was a medic on Omaha Beach. This is a man who gave his life for other people. When speaking of himself, why can't I think? Why am I words so hard to get? I can't finish the thought, I can't finish the sentence. And this is so hard, but make me do it. We can't quit. All right? Again, addressing some of the things that I had just said, some of these medications were given to him for reasons that were very difficult for me to understand. At one point, I went in, he's tied down. I said, why is this? The nurse said, oh, he's pulling his cannula out of his nose. So I looked at him, I said, why are you pulling the cannula out of your nose? He could not speak because he had to take it down. I just put my finger in his nose. There's a big sore in his nose. The cannula was cut off. Because of that, he was tied down, and because of that, he was given more medication. No one asked him. This is what the result of this was. Another point, he was in there, and I was there that day. They came in and established fingers because now some of these medications cause diabetes, sugar. They came in without waking him up.
without telling him what was going to happen. They stabbed his finger, he pulled away, and he said, I can say no, I'm a man, I can say no. She said, he's a bit agitated. I said, I would be agitated too if someone did that to me without my permission. The next day, Seroquel and Xanax, he was put on both because the LPN called in and said he was agitated without any permission from any family member. Oh, and now, again, to go back on this, I'm sorry, I have to take 2 seconds. He did get bed sore, that was the end of him. But what I'm saying, and this is uncomfortable. So I'm going to show you when people that won't have bed sore. This is the bed sore he got. This is the bed, 2 weeks after going on this medication to start. Eventually, there were so many things wrong that he eventually died a difficult, painful death, with him still struggling to survive. So again, the truest measure of how we treat as weak numbers. That's the story, Bob.
Okay. Next, Penny Shaw will testify. She is a Manor board member and a nursing home resident who herself was a victim of the overuse of these psychoactive drugs.
Hi. I'm going to turn my chair a little. My name is Penny Shaw. I'm a nursing home resident with Guillain-Barré, which is a rare neuromuscular disorder, who is a survivor of unnecessary psychoactive drugs, including antipsychotics when I was not psychotic. I've had a 16-year medical journey, 4 months in ICU, a year in a respiratory rehabilitation hospital, and now 15 years in the nursing home. For 5 years, I was mostly bedbound with a tracheostomy and feeding tube. Then, in 2010, I joined the resident council of my facility and learned my rights, including the one that I could read my medical record. I thought it might be interesting, but instead I was horrified. I discovered I was being given 8 unnecessary medications crusted in applesauce, including psychoactives. These were Lasix for edema. I had no edema. Prilosec for GERD. I did not have that. Oxycodone for pain. I had no pain. But worse, inappropriate psychoactive drugs. There were Zyprexa and Geodone for psychosis NOS, but said I had no symptoms of psychosis, right? Prozac for depression, Ativan for anxiety, and Ambien and Trazodone for sleeplessness. This was in 2010. Knowing all these diagnoses were incorrect, I had all 8 medications discontinued at the same time on one day without repercussions and have never taken any since. And I mention those that are not psychoactives to show you how inappropriate the drugging is in nursing homes. Even today, I remain stunned at the poor medical care I received. I tried to figure out how I'd been on these psychoactives. My discharge summary from acute care had said no evidence of psychosis. My year in the respiratory rehabilitation hospital had been traumatic in the sense that I lived in a cubicle with no TV or other distractions, except for being occasionally transferred to a wheelchair and pushed around the facility. I mostly lay in bed, alert, bored, unengaged, and lonely. Staff found me annoying as I would turn on my call light and hope that someone would come talk to me for a few minutes. At night, the curtain of the cubicle was closed, leaving me in a very, very small space and unable even to see the staff person pass down past the cubicle. I was totally alone. I yelled out to ask that the curtain be opened to no avail, which annoyed staff as they complained. I believe I was put on the psychoactives in the respiratory rehab hospital to squelch these behaviors of turning on my call light and asking for the cubicle, the curtain. It was a cubicle with curtains on 3 sides. At night they would pull the 4th one. I only asked that that be opened. You couldn't see much. There was just a carpeted walkway. You could see the person across on the other curtain. Couldn't see much from the bed and nothing. I was not able to confirm this happened in the respiratory rehab hospital, as my medical records years ago went to Iron Mountain, and I've been unable to retrieve them. But you can see, in my opinion, how easily patients get unnecessary drugs because they are seen as troublemakers by needing attention and, in my case, a larger space with view. What concerns me as I am testifying this today is I was never told I was being put on these medications. As someone who was alert and whose graduate school minor was clinical psychology, I was capable of understanding both the diagnoses and the proposed treatments, which I would, however, have refused. This is in contrast to when I was inpatient in 2008 for diagnoses of diabetes and education on how to manage my diabetes, where everything was above board. Some years ago, I had a conversation with the director of nursing of our facility, who told me that commonly residents arrive from acute care on unnecessary psychoactives, and then facility staff are responsible for weaning them off. I am a survivor of extremely dangerous medications, psychoactives, which, among many possible adverse events, can cause confusion, falls, stroke, and even death. Other individuals are not so lucky, as you've just heard, and they have been harmed. Every person, in my opinion, or their legal representative should be fully informed and give written consent for their use. That the consent be written is essential. Oral consent, anybody can say they were told that, and the person agreed. Without written consent, we do not know that really happened. I urge this committee to support legislation to put into Massachusetts law protection for basic consent rights for all patients covered in this bill. Thank you for listening to me.
Good afternoon. My name is Leslie Vogel, MD. Can you hear me? Okay. My name is Leslie Vogel, Dr. Leslie Vogel, MD, and I'm a psychiatrist. I specialize in the medical diagnosis of mental status change. And behavioral changes always have a reason, often a complex interplay between medicine, neurology, and psychiatry. Behavior, even the most aberrant, aggressive, or self-destructive, is not a diagnosis per se. It is just a symptom, a clue, that something is seriously wrong underneath. We can't fix the behavior if we don't know what's causing it. So here are some real-life stories about challenging behaviors which appear psychiatric and the surprising causes behind them. Case 1, Miss A is an African-American woman in her 80s, a retired certified nurse's aide with impaired vision and no psychiatric history. She is admitted to a nursing home for long-term care. She has stopped walking. She has visual hallucinations of, quote, men trying to fight me, injures herself by falling out of bed in the process of defending herself against these hallucinations. Her hallucinations are attributed to her visual state and nothing can be done about them, quote. Instead, she's given ever-increasing doses of an antidepressant to help her cope with anxiety. The medicine makes her shaky, more anxious than ever, and discouraged. Psychiatric consultation reveals that Miss A uses an eye drop medication. These eye drops are known in some patients to produce visual hallucinations. In a joint team effort between psychiatry, geriatrics, and pharmacy, the eye drops are substituted with a different prescription, and her hallucinations gradually fade away. As a result, her mood improves, she starts to walk again, she's no longer fighting those men and falling out of bed so she can actually sleep. Her antidepressant is tapered and she feels calmer and happier. The nursing home receives multidisciplinary in-services about eye drops and the little known but profound effects they can have on behavior in vulnerable individuals. Case 2, Miss B is a Caucasian female in her 60s, retired office assistant with multiple medical problems and bipolar disorder. She's treated with high doses of antipsychotics because, quote, otherwise she's disruptive. This quiets her down. This keeps her sedated, in bed, and she keeps falling, sustaining fractures. Finally, she's admitted to the nursing home, and now it appears that her falls are due to her antipsychotic medication. Her entire body is shaking. The nursing home team decides to taper both her antipsychotics and antidepressants in hopes of neurologic improvement. After several weeks, she's walking again, her affect is brighter, her tremors are reduced. However, she's transferred back to the hospital for medical treatment, and they put her back on antipsychotics, mistakenly thinking they'll stabilize her. Instead, she has a severe neurologic decline, which could have been avoided with a thoughtful, informed, written consent process, addressing the history, risk, and benefits of antipsychotic treatment for this individual. Case 3, Mr. C, Caucasian male. Oh, okay. Wrap up with this or? Oh, okay.
Any questions from the committee? Seeing none, thank you all very much for your time and for your testimony.
Thank you.
Thank you.
Thank you all for being here. Calling up rep comments.
afternoon.
Good afternoon.
I will be very brief because I know we have many members of the public here waiting to testify, so I don't want to take up their time. I am here in support of House Bill 1144, an act relative to safe patient handling in certain health care facilities. This bill was reported out of the committee favorably last term, so I'm hoping it does again. Basically, it creates a safe patient handling protocol, which in 3 bullet points will save money, protect our healthcare workforce, and protect patients. I've submitted testimony that is signed by over 60 of our colleagues, and I would ask that you report this once again favorably out of committee. So I thank you for that.
Thank you very much.
Thanks. See, I only use 30 seconds, not 3 minutes. Thank you.
Senator Timmelty.
Hello, Madam Chair. Mr. Chairman, thank you very much. I also thank you for turning up the heat in this room. I appreciate it greatly, and thanks for having me here. I am here to testify in favor of Senate Bill 1275, which is an act to require the Department of Public Health to conduct a study of the health impacts of airplane flights on residents of communities that are within the Massachusetts Port Authority, CAC. Quite frankly, we have a public health crisis in the offing, in my estimation, with the impacts of airplane noise, with the heightened traffic patterns that have been imposed upon the area. Obviously, the Massachusetts Port Authority and the airport are a booming airport, and obviously that is great for the economy, but it is not good for the public good. Only within reason. The constant barrage of noise and the public health risk proposed by flight traffic patterns are completely inexcusable in my estimation. Overhead flights cause extreme disruptions to daily life, affecting sleep patterns and lessening individual capacity. This legislation will establish an avenue to work towards alleviating these deplorable conditions. The goal of the study is to elucidate the threat to public health and provide concrete evidence to supplement anecdotes that we hear on a daily basis. It is our hope that this study would further demonstrate the dire need for a reduction in airplane traffic in the affected communities. Numerous academic studies have found evidence of wide-ranging deleterious health effects deriving from heightened airplane traffic. The Mass Institute of Technology Partnership for Air Transportation Noise and Emissions Reduction, in a review of the literature on the topic conducted in conjunction with Purdue University, found the harmful manifestations to include cardiovascular issues, sleep disturbances, and cognitive impairment in children. Specifically, the Harvard School of Public Health and the BU School of Public Health have found on average areas with increased volume in air traffic endure an increased cardiovascular hospital admission rate per capita. These studies are merely just a sample of the work that has been done. This legislation, which would mandate a DPH study, will be the first step in promoting a better understanding of the public health crisis at hand. I respectfully request that this bill receive a favorable report from the committee, and I'd be more than happy to answer any questions that the committee may have.
Any questions from the committee? Seeing none,
Thank you, Madam Chair. Thank you, Mr. Chairman. Greatly appreciate it.
Senator Chico? Good afternoon.
Good afternoon, Madam Chair, Mr. Chairman, members of the committee. I am here to testify in favor of Senate 1199, a bill that is before you that was filed by Senator Flanagan. I did not originally co-sponsor this bill, and I'm trying to get my name on it, but under the rules of the Senate, we need to pass an order to do that. And so we will be seeking the opportunity on the Senate side to ensure that those members that are interested in signing on to this bill can do so. I'm not going to go into every detail of the bill because I know that both the chairs and your staffs and everybody on the committee will be looking at the bill. But I want to give you a real world scenario that is going on right now in Taunton, Massachusetts. Since Morton Hospital in Taunton opened as a community hospital, we have had maternity care available at a community hospital in the city of Taunton. The whole time that Morton was a not-for-profit institution, we had maternity care there. People would come and give birth. It is a basic part of what you would think a community hospital would be all about, a family hospital would be all about. A few years ago, Stewart Hospital System acquired Morton, and as you know, throughout that process, there is a community benefit piece that they have to commit to, and there are certain standards for a number of years that they have to commit to. But then after that, there is the opportunity for them to come in and try to cut back on a lot of the services that the community rightfully enjoyed. Public health access to services. So what is happening right now is that we are starting to see various aspects of care in our public health system being taken away. And one of the things that they have done is filed a notice to discontinue maternity services at Morton Hospital. And I see this as a very, very serious public health issue. I can't get into a lot of the specifics because of HIPAA. It would be a HIPAA violation. But we have had situations where people have come to the hospital, going to the emergency care part of the hospital after they have had a problem and presented at the hospital to be told to take a taxi to Brockton. Senator Brady and I have been talking about this issue. There's an issue in Brockton because a lot of the patients are being diverted to the Brockton facility, and there's a backup there now. So I simply want to say I'm in favor of this bill, although I don't think the bill goes far enough. I think the bill actually needs to go much farther, and I look forward, hopefully, to working with your offices to try to come up with appropriate language to make sure that in certain geographic areas where community hospitals already exist and services have been provided for countless numbers of years, that in order to operate a hospital facility here in the Commonwealth, this should be one of the minimum services that are provided to the patients.
Thank you very much for your testimony.
Okay.
Any questions?
Thank you very much.
Senator O'Connor, and I apologize, I did not see, there were so many O's.
Chairwoman Hogan, Chairman Lewis, I'm here to testify on Senate Bill 2239, an act establishing a newborn health and safe sleep pilot program. This bill was brought to my attention by my mother. She's a 40-year neonatal intensive care nurse at St. Elizabeth's Hospital, before then St. Margaret's. And a situation was brought up where a child was born 6 months premature. And after it was nursed back to health, a few days later, the infant was suffocated in an unsafe sleep condition with their mother. And so it came to my attention that there's a program out there that allows for municipalities and the Commonwealth to enter into a agreement to allow for a pilot program for safe sleep for our infants. And essentially this legislation, the genesis is from Finland. It was established approximately 75 years ago where they had a high infant mortality rate, and they started giving out free boxes, basically 2 feet by 3 feet by 2 feet, with approximately 50 items inside. In order to get this box, what you'd have to do is you'd have to complete a program in your 4th month of pregnancy. And with this program, it essentially connects the government with the individual who may not have the means to take care of their infant who is in the most vulnerable stages of their life. So what this bill would do would essentially allow for the Commonwealth of Massachusetts to promulgate regulations within DPH to allow for these baby boxes to be distributed in the Commonwealth of Massachusetts. Right now in the Berkshires and in the Cape, they currently have baby box programs where network organizations, community health centers, and hospitals distribute these boxes already here in the Commonwealth. The states of California, New York, and New Jersey have also adopted legislation in order to do this. And essentially what this will do is allow for us to give infants a free, safe, and portable place in which they can sleep. Far too often we see of infant mortality rates in the 4.4 per 1,000 in the Commonwealth of Massachusetts, and we continue to see an unfortunate situation where children are dying and they don't have to. And this baby box program will connect the Commonwealth of Massachusetts to these individuals from a multitude of demographics in order to address the needs they may have for their child, whether that be behavioral health, whether it be preventative health, or whether it be simply just the box itself in order for that child to sleep in. I think that this is one of the pieces of legislation that many people can get behind. There's bipartisan support for this piece of legislation. And at the end of the day, I think that what we need to do is ensure that Massachusetts is truly a sanctuary for the health and well-being of all populations, especially in the most vulnerable stages of life. And for mothers who might not have the means to protect their newborns, that we give them a tool that connects them with the Commonwealth and with all of the opportunities and resources that we have in order to make sure that they have everything they possibly can to bring that child to its fullest potential. Thank you. And we do have a baby box up in our office if anyone would like to check it out. Thank you.
Representative Garland?
Thank you, Chairwoman Hogan and Chair Lewis, and to all the committee members. Hello. Thank you for taking me out of turn with great respect to the many people that come in to hear, to give testimony today. I would like to take a moment of personal privilege and tell you I am deeply concerned and invested in every item on your agenda today. But I would like to express my support for House 1144, the Safe Lifting Bill. And I would like to talk to you about H2459 and H2460. As the committee well knows, these bills are about the retail and urgent care clinics, and both bills combined subject the retail and urgent care clinics to DPH licensing, prevent clinics from discriminating on the basis of insurer, and subject clinics to determination of need process. I'm more than willing to work with the committee in more detail on that, and I'm submitting written testimony today. Thank you for your time.
Thank you so much. Is there anyone here to testify on House Bill 1127? House Bill 1127. House Bill 1136. House Bill 1136. House Bill 1137. House Bill 1140. House Bill 1140. So we come to House Bill 1143, Senate Bill 1199, and we have Mass Nurses Association. Karen Coffin, Lisa Goss, and all the other please. Right now. Welcome.
Good afternoon. My name is Karen Coughlin. I am the Vice President of the Massachusetts Nurses Association. Thank you for allowing us to provide testimony to you today. I'm here today to speak in support of House Bill 1143 and Senate Bill 1199, an act relative to the closing of hospital essential services. So all across the Commonwealth, we see hospitals and healthcare companies closing essential services to the detriment of the communities that need these services. And over the past several years, all around our state, nurses have been continuously advocating for their patients and their communities each time a proposed closure has occurred. In 2010, it was a 15-bed psychiatric unit at Burbank Hospital. In 2012, Brigham and Women's Faulkner Hospital closed a medical detox unit. In 2013, Morton Hospital shuttered its pediatric unit. That same year, North Adams Regional Hospital closed its inpatient psychiatric unit and its critical care unit before the hospital itself illegally closed with just 3 days' notice. In 2015, Quincy Medical Center was closed, leaving a city of under approximately 100,000 people without a hospital. And this year, UMass Memorial is moving ahead with the closure of an inpatient psych unit, and Morton Hospital is attempting to close its maternity unit after temporarily closing it this fall and not reopening. There's a nurse here today with us, Holly, who can speak to what is happening there. In almost all of these instances, the Department of Public Health held public hearings and stated that these services and closures should not happen because the service was essential to the community, and yet in each case, despite the finding of the DPH, the unit or hospital was closed. The elimination of these services has a profound negative effect on the care of patients in these communities and puts a strain on other, already overburdened health systems. Residents of North Adams and surrounding communities must now drive long distances to reach a full-service hospital. We routinely hear of psychiatric patients, and I'm a psychiatric nurse, aborting in our state's emergency departments because there aren't enough beds, and yet 2 hospitals closed inpatient psychiatric units. And Morton Hospital permanently closes its maternity unit. Women who arrive at Morton Hospital in labor will now be sent to other facilities. This is not acceptable. And that is why I am here today, joined by other nurses, to ask this committee to advance House Bill 1143 and Senate Bill 1199 out of committee. While these bills do not solve every problem around the closure of essential services, they do take steps to improve the process around notice and community involvement. And that's a good first step. Thank you for your time and attention.
Good afternoon. My name is Lisa Goss, and I'm here to testify in support of House Bill 1143 and Senate Bill 1199. I'm a registered nurse at UMass Memorial Medical Center in Worcester on the inpatient psychiatric unit, and my unit is very unique in the state in that we are able to provide both comprehensive medical and psychiatric care to patients. Last December, UMass Memorial announced their decision to convert 13 of our 27 psychiatric beds to medical surgical beds, despite the fact that our unit was always full. And add to that, our emergency mental health department is always full and usually overflowing into the general emergency department. The hospital's rationale was that they didn't have enough medical beds. At the same time, it's a well-known fact that there are far too few psychiatric beds statewide, and this is certainly the case in Worcester. Patients with mental illness are already a marginalized population who often require comprehensive community care and support to be able to take care of themselves, and these are provided best locally, including when they need inpatient care. The hospital announced their alternative plan was for these patients to be sent to a new facility in Devens, which is a full 45 minutes away from Worcester. It's away from their support systems, their families, and this facility is also not able to provide any medical care. So there was a tremendous outcry when the hospital's plan was made public. The Worcester City Council passed a resolution unanimously to oppose the closure. The entire Worcester legislative delegation and many of the Central Mass Caucus opposed it. And prior to and at the DPH public hearing, staff from my unit, staff from all the other hospitals in Central Mass, family members of people with mental illness, representatives from the National Alliance on Mental Illness, and most importantly, former patients all spoke out that these 13 beds should not be closed. Ultimately, the DPH also agreed that they should not be closed and decided they were an essential service and issued a strong opposition to the closure. But despite all of that, the hospital did choose to close the beds, and they, within a week of getting that decision, they, dropped our census from 27 to 14. As a mental health nurse and advocate, it is stunning to me that the DPH has no real authority to actually protect the public's health. Since the closure of our beds, Our medical and ICU units have seen significant increases in the amount of psychiatric patients being admitted there inappropriately, and they're waiting for longer periods of time because they can't get a bed on our unit, and we can care for these people that other hospitals that are standalone cannot because of their medical issues. So if the DPH had a way to force hospitals to go along with their decisions, these patients would be on my unit in the appropriate milieu getting care that they would deserve. So I ask that you please advance these two bills out of committee. Thank you.
Okay. I can speak pretty loud anyway. Good afternoon, my name is Holly Shea. I'm a nurse in the maternity unit at Morton Hospital. I've been a nurse for 17 years and I've worked at Morton a little over 2. In October, I was informed the unit would temporarily be closed for 2 weeks, with all patients being diverted to Good Samaritan Hospital in Brockton, and we would be expected to work our regular shifts alongside this emergency room to assist if a labor patient came in. We would not have a pediatrician, we would not have an obstetrician. It would be the ED doctor and the labor and delivery nurses. The reason for the closure was that the pediatricians were not able to provide continuous coverage for the hospital for the next few weeks, and once that was rectified, the unit was planned to be opened again. Stewart Healthcare never had any intention on opening our unit again. They've said they've tried tirelessly to fill the holes. Sorry, I'm very nervous. Stewart claims to be able to come to an agreement with the pediatrician group and claim they have been working tirelessly to find coverage. These are all false statements that Stewart is making. I know this because we have community pediatricians willing to cover, and we also have a nurse practitioner and 2 pediatricians willing to solely work at Morton. Yet Stewart continues to say they cannot fix the situation. The community in the city of Taunton is one of low socioeconomic status, and most of our patients walk to the hospital and take the bus or cab. Our patients are already at disadvantage and have many obstacles to overcome in order to have healthy pregnancies and babies. By closing the maternity unit, an essential service that is desperately needed, Stewart has put our women and children at incredible risk. It's put our community at risk. A 2016 study in the Maternal Child Health Journal found that every 15 minutes a woman had to travel had a direct correlation on the risk of birth before 37 weeks. So, if a woman had to drive 45 minutes to get to a maternity service, her risk was 50% greater than one who only had to drive 15 minutes. Our patients walk, take a taxi, and a cab. Good Samaritan in Brockton is 19 miles away, 30 minutes with regular traffic, 20 minutes with light traffic. How are they going to get there? What is happening at Morton is tragic and a disservice to our community. Unfortunately, it is not uncommon. Hospitals across the state are shuttering units and facilities, ignoring the recommendations of the Department of Health and the outcry from members of the community. More and more hospitals are emboldened to flout the laws of the state, knowing that there is little that DPH can do. Even when hospitals follow processes, even when DPH says a service is essential and should remain open, we still lose those essential services. The time to act is now. This bill would take steps to address the flaws that exist in the system. My family at Morton, my family at home, and my community are fighting to retain the maternity unit at Morton, but we are not overly confident. We have seen how this plays out in other hospitals, right? In the experience we have had already with Stewart closing our pediatric unit. Please give us some hope. This is why I'm asking to advance the House Bill 1143 and 1167. It's time to improve the process, and maybe another essential service, this time in your community, won't be closed. Thank you.
Are there any questions from the committee? Senator, thank you, Madam Chair. Thank you all for your testimony. So just can you help us understand better today, under the current law and current regulations, if DPH conducts a review and determines that it is an essential service, therefore it should continue to serve the community, and what are the repercussions if the hospital or health facility does go forward with progress, does not follow DPH's?
I just want to clarify a little bit. You're asking what the repercussions are?
Yes, correct.
If DPH announces that it's an essential service, the hospital closes anyways.
Anywhere closes that service.
Okay, so
does the AG have to take action? Should he? What should happen today? What is it?
What typically happens is that, a public hearing is held prior to the closure. It's, there are certain time constraints. that DPH has in order for that to be done, and then the public comes out, there is an outcry, they declare the services are essential, that they're needed for the community, and then it closes anyways. And that's the end of the story. So this is something that we say no longer, we need to have some teeth, at least start the process so that these essential services and the communities and our patients are placed at risk. Because this is what is happening across the state every time they close an essential service. People have to go further for their care, whether it's psychiatric, whether it's maternity, whether it's pediatric, whether it's detox, etc.
So what I'm trying to get at is undercurrent law with the Attorney General stepping in those cases. Is that
no
her discretion? Does DPH have any additional authority?
No. No.
Thank you.
Thank you. Oh, sorry.
It's a question of clarification. So at times, some of these services are being closed, but others are being expanded, and that was certainly the case in the district in that that's what the initial that's versions, I understand. And so I think part of it is not just that there's a closing of the service, at times there's a trade-off in terms of another service being escalated. So I think that one of the concerns that we have is, quite frankly, both services are probably essential. So how do we deal when we do have the sense of needing to provide still service that is being closed? It certainly probably also have challenges of providing regular service in the other areas. So I just think it's important that this isn't being closed necessarily as being not part of the hospital being affected, that it is most times being used for some other service within the hospital. And is that the example of the closing of the maternity? Is it being now reallocated to be used for something else? Or is that
Right now, we're still being brought in our regular shifts. We're on the unit with no patients, and we're there to assist in case somebody comes to the ED. There's no plans that we have been told they're going to use it for a different reason, but we're going to work with no patients. I mean, a nurse to go to work, not to take care of somebody, it's just...
No, I agree, and my only clarification is that sometimes these things are, the space is being utilized for something.
We have not been told that it's going to be utilized for something different. I'm sure that it would.
Multiple levels of things that need to be addressed here.
And I would say, that being said, that when you take a look at the closures that have happened, it's a very rare instance when it's used for something else. For instance, what you're talking about, like at UMass Memorial, there were flat-out closures, though, with psychiatric units throughout the state, and not a reopening of other services. And at times, we believe that may have more to do. Unfortunately, it doesn't have anything to do with patient care. It's got to do with money.
I'm the sponsor of this bill, I agree with you. I think probably just for that education of the community, it would be actually good to sort of provide information relative to straight out closures and something else.
And I believe that we could certainly provide that to this committee.
I think that would be helpful.
Yeah, that would be, yep.
Thank you. Is there anyone else here to testify on House 1143 or Senate Bill 1199? We will close that and move on to House Bill 1144 and Senate Bill 1167. And we'll call up the Mass Nurses Association, Beth Pickney and Dan Brett.